to Psychiatry Bootcamp. Today we are covering a topic that is very close to my heart, and I think close to the hearts of many across the world. This topic gets to the core of what I love so much about psychiatry. Our brains and our personalities are part and parcel of what makes us human. Our brain and personality allow us to connect with others and ultimately make it possible for us to experience love, which, in my opinion, is the whole point of, well, everything. People who suffer from dementia have a progressive decline in functioning, and the effects of dementia go far beyond memory issues. Dementia can lead to personality changes and other problematic behaviors. There's nothing quite like watching someone you love change right before your eyes. And I'm hoping that this podcast episode puts some good information out into the world that can be used not just by doctors and other healthcare workers, but also by friends and family members of people with dementia. We're going to talk about the various behavioral problems that often come with a diagnosis of dementia, and then we will spend some time discussing various management strategies. What I really want you to hear is how it is impossible to cover this topic without delving into the humanity of it, and Dr. Grossberg is a great guide for us in this regard, continually reminding us that we need to know the person, not just the disease. Psychiatry Bootcamp is brought to you by Simple Practice. Simple Practice has been a great partner for us because, as you know, I find time with the patient to be a therapeutic intervention more than documentation. So Simple Practice makes documentation easy. They have an AI-powered note writing tool integrated within the EHR, so it's a true all-in-one EHR. It's HIPAA compliant, it's high trust compliant, and now it includes AI. What more could you want? Simple Practice saves you time so you can focus on what matters most. They're offering Psychiatry Bootcamp listeners a 30-day free trial for their AI note taker and an exclusive 7-day free trial and 50% off 4 months for Simple Practice EHR. Visit simplepractice.com/bootcamp for this offer. That's simplepractice.com/bootcamp. Psychiatry Bootcamp is brought to you by Beat the Boards. Listen, Beat the Boards is offering us a ridiculous deal. Bootcamp listeners now get free access to over 4,400 exam style questions for USMLE Step 2 and over 4,500 questions for USMLE Step 3. This is not a discount. It's completely free. Don't miss this opportunity. Go to beattheboards.com/bootcamp to get started today. I used Beat the Boards to study for my own board exam, and I found that it made the exam a breeze. It really reflected the real exam. Give it a try. beattheboards.com/bootcamp. All right. Well, welcome to Dr. George Grossberg. And like all of our guests, Dr. Grossberg, I am going to ask you to introduce yourself to our audience.
I can do that. Thank you, Mark, first of all, for inviting me. I'm looking forward to this kind of interview or podcast. So as you mentioned, I'm Dr. George Grossberg. I'm a geriatric psychiatrist and director of the Division of Geriatric Psychiatry at St. Louis University School of Medicine and our Department of Psychiatry and Behavioral Neuroscience. The other part of my credentials I'm very proud of is that just 6 months ago, I accepted being the inaugural Henry and Amelia Nasrallah Endowed Professor in Geriatric Psychiatry, which is a 5-year commitment. So I won't be retiring for a while. So that's a good thing. And it can be renewed. So we'll go from there. But in my day-to-day work over the last 3 to 4 decades, I've basically been involved in seeing patients and families with a variety of brain-related disorders related to aging, things like depression, dementias, and so on. I've been involved on a daily basis in teaching medical students, residents, fellows, and others. And I've been involved in research. And most of my research has really focused on working with small and large pharma companies that are developing new treatments for both Alzheimer's disease as well as our topic today, the neuropsychiatric symptoms or the BPSD, specifically related to Alzheimer's disease.
Beautiful. Well, you already touched on my first couple of questions for you. So unfortunately, while I went to med school at St. Louis University, I did not have the pleasure of training underneath you. I did not do a residency here, so I did not get to train with you. But as I kind of run medical student education now, I do have the pleasure of reading all of the evaluations that our medical students leave for you, and they are reliably effusive, gracious. They really, really appreciate having you as a mentor. So I want to start there. What would you say has been the key to sustaining your focus, your passion throughout your long career now as a clinician, researcher, and beloved educator?
Yeah, I think that's a good question. I actually have thought about that in the more recent past. I think more than anything else, I think it's the passion and love for the field of geriatric psychiatry. And I'll share with you a very quick anecdote. You may or may not know that I have five adult children, but three of them are doctors. But my oldest child, his son, is a neurosurgeon at Emory. Okay, he's actually training director at Emory at neurosurgery. And he called me fairly recently. He never calls me, but he called me fairly recently because he had seen a survey of job satisfaction by specialty choice among community based physicians. And he said to me, he said, Dad, you'd never guess which, or maybe you would, which specialty had the highest job satisfaction rating at 97%. And it was geriatric psychiatry. And I was not at all surprised. His specialty was much lower down, but I think it's my passion for the field that has really kept me going all these years. And I've always seen myself in the academic world as being kind of different than in the private practice world. I've never been in private practice. The main difference is that I really like to teach. And you mentioned medical students. I like to teach at all levels, but when I gather a group, let's say, of medical students, residents, fellows in my office or in the conference room, and we're discussing a case, and I'm trying to get some points across to them. One of the things I say is that now in this room we have some really bright people. We've got residents, we've got fellows, we've got medical students, but there's only one group here in the room that's actually paying for their medical education, and that's our students. Even though we don't pay residents and fellows a whole lot, but at least they're getting something, okay? But the students are paying, often paying a lot. So they're my primary focus, and of course, the ancillary focus would be, the other trainees as well.
Beautiful. So you feel like you had to fall in love with the field first, and then sort of through that love for the field, your desire to share it, and it kind of grew from there.
Exactly.
You used two different phrases when talking about today's topic during your introduction. You used the phrase neuropsychiatric symptoms of dementia, NPS, and you mentioned the behavioral and psychological symptoms of dementia, BPSD. So I'd like to make sure we're all on the same page here when we start. How has this nomenclature changed over the years, and what's kind of your preferred term, et cetera? What's the term of art these days?
So that's a really good question because this has been a topic of discussion and debate actually worldwide among geriatric psychiatrists and cognitive neurologists and people who really specialize in dementia work. So the initial terminology goes back 20 years plus, is BPSD, which is behavioral symptoms, basically behavioral and psychological. It's supposed to be signs and symptoms, but behavioral and psychological symptoms of dementia. That was coined by the IPA, the International Psychogeriatric Association. And when I travel to different countries, different parts of the world, clinicians know that terminology, BPSD. On the other hand, in the US, over the last few years, people who specialize in the dementia arena have really advocated for changing the terminology to neuropsychiatric symptoms, NPS, of dementia. And whether you call it BPSD or neuropsychological symptoms, we're basically talking about an array of what I call psychiatric manifestations of the dementias.
So then I'd like to ask you to go, I know this is an extremely broad topic. As much as possible, could you give us a definition then of BPSD? What types of signs and symptoms are we talking about?
So, BPSD, I think the original terminology, if we look at it kind of more generally, the behavioral and psychological signs and symptoms of dementia encompass a whole array of clinical signs and symptoms. Everything from agitated behaviors, and that's a spectrum from mild anxiety, irritability, to more agitated behavior to even overtly aggressive behavior to psychotic symptoms. These are all very common, in particularly in Alzheimer's disease, which is the best studied, which would include delusions and hallucinations, to mood disturbance, particularly kind of depression. And then probably the most common of the BPSD or neuropsychiatric symptoms, apathy, or what I call being a serious couch potato. So, and then there are some others, but those are the key kind of neuropsychiatric or BPSD that we see in dementias. And of course, the presentations as to when they appear, the frequency is going to vary according to the type of neurocognitive disorder or dementia that we're talking about.
And on that note, do you think it's fair to cover this in our one-ish hour as a global sort of spectrum of signs and symptoms? Or do you think that it would be more appropriate to first talk about the different types of major neurocognitive disorder because the BPSD are going to follow directly from the type of major neurocognitive disorder that the patient is experiencing?
Well, it's a good question. It's a broad topic. There's no doubt about it. Um, I'm actually involved in kind of trying to put it all together in one paper. And I guess the closest to addressing the broader topic that I've come is in a publication recently for the Gerontologic Society of America, where we talked about a decision tree for healthcare providers to approaching agitation in Alzheimer's disease. That's just one of the neuropsychiatric symptoms. So you could make a case for kind of a brief kind of overview of each of the major neuropsychiatric symptoms, specifically in Alzheimer's disease, because that's the best studied, but also in related disorders, whether it's Lewy body dementia or vascular or Parkinson's or frontotemporal.
So we'll try to cover it broadly now, but to your point, hopefully soon there may even be decision trees, algorithms for if you can differentiate which type of major neurocognitive disorder is underlying the behaviors. Maybe we can make some more targeted interventions. But for the bootcamp audience, we'll speak a little more globally. I am going to just use NPS, neuropsychiatric symptoms. That seems like less of a mouthful and the more recent term. So we'll just use that terminology for this episode. How common are neuropsychiatric symptoms of dementia overall?
Extremely common. So if we look at the totality of neuropsychiatric symptoms, almost 100%, well over 90% of dementia patients. And again, when I mention dementia patients, we're also talking about major neurocognitive disorders, which is the more current terminology. But whether you're looking at Alzheimer's disease or Lewy body dementia or frontotemporal or vascular, the mixed disorders, we even had a patient just this past week that has late TDP-43 type of dementia, was basically 90 years old. It's a very special entity. If you include all of those, close to 100%. So almost everyone at some time during the course of the disease will manifest one or more of the neuropsychiatric symptoms. But again, best studied has been Alzheimer's disease.
Does NPS ever show up first before you see the memory impairment, the impairment in activities of daily living?
The answer is yes. Okay, but again, we're going to use Alzheimer's disease because that's the one we know the best, but also include Lewy body dementia because that's a unique area where the neuropsychiatric symptom may be what brings the patient in. So we will often get someone that comes to us who's never had a psychiatric history, an older adult brought by family, because mom or dad is really gone crazy and she's seeing things, or she thinks there's a family living in the basement with kids. And no matter how many times we go down there with her or we don't see them, she's convinced that they're there. So that's one of the unique, I think, neurocognitive disorders that presents often with a unique psychiatric symptom, in this case, psychotic symptoms, usually uh, either hallucinations and or delusions. But in Alzheimer's disease as well, if we think about MCI, a mild cognitive impairment due to Alzheimer's disease, it is not uncommon, even during that stage, for patients to have either depression or anxiety. Sometimes, even preceding the MCI stage, there may be some depression and anxiety symptoms. and then we subsequently diagnose Alzheimer's disease. So we feel that the neuropsychiatric symptoms can basically be seen throughout the course of disorders like Alzheimer's disease. And in some instances, they may be the presenting feature.
Beautiful. Thank you. Very clear for us. Um, I think at this point, I'd like to break down the various common neuropsychiatric symptoms. I'll pitch them to you, and I'd like you to kind of paint a picture for me of what they typically look like in these patients. Is that fair?
Yeah, that sounds good.
Apathy. How does apathy typically present for you?
Well, you picked the most common one. So apathy is a very interesting phenomenon, and there are now rating scales for apathy. They're way too complicated. What I talk about with apathy is a patient who I see as being a serious couch potato, a total lack of motivation, lack of interest. So this is again, it's seen in all of the neurocognitive disorders. We've studied it best in Alzheimer's disease, so we'll kind of talk about that. But let's assume that we have a typical Alzheimer's patient. You could see it in all the stages, mild, moderate, and severe. It doesn't go away. May get worse, but not necessarily. Where they come with the family for a routine follow-up. And we always ask about behavior change. We ask about personality change. Is there anything happening that's making it harder for you to take care of your loved one, whether it's a he or a she? Usually it's a she, could be a he. And apathy isn't often talked about by care partners because the quiet, kind of couch potato type patient doesn't make waves. I mean, it's not like someone who's hallucinating or paranoid or agitated or gets, irritable with hands-on care. They don't make waves. They're relatively quiet, but it's very frustrating to the care partner. Um, because what they tell us is that, my husband just sits, watches TV all day or doing whatever. I can't get him interested in anything. So when I ask him and I say to him, gee, it's a beautiful day outside. Why don't we go for a walk? Or, we've been talking about some movie that we want to see. Hey, there's a matinee, later today. Why don't we go see this movie together? Or there's going to be something on television that you and I can watch. Always the answer is no. They're not interested. One of the things we actually recommend as a way to kind of deal with apathy or lack of motivation is not to ask, is to say to that person, come, we're going. We're going to see this movie. You're coming with me to dinner. We're going to our favorite restaurant. Don't ask. Because if you ask, the answer is always going to be no. There are also some unique treatment approaches when the apathy gets so frustrating that the caregiver is ready to throw the towel in. There's some good evidence, and this is off label, using psychostimulants, particularly methylphenidate. And we actually use methylphenidate pretty generously in low doses to kind of counteract apathy, to kind of energize the individual. And that can be often very useful. But more useful is the approach.
Really good example there of where psychoeducation can make a really concrete difference for the patient. I can imagine a caregiver just really at wit's end with someone who they can't seem to get to interact with them at all. And maybe they start to blame this person. Maybe it's what's happening to my spouse of 30 years where all of a sudden they're no fun anymore. They don't want to do anything anymore. And when they come for a professional evaluation and you can humanistically describe to them, this is the phenomenon that we're seeing. This is how we understand it. This is how we recommend you approach it. I can almost feel a weight lifted from the shoulders of the caregiver to think it's not that my spouse is a bad person, that this is some sort of moral failure, that they don't like me anymore. It's that this is the disease process, and now I'm under the care of someone who is an expert and can help me.
That's exactly right. You could run my clinic. Absolutely. Absolutely. No. That's exactly what we tell them. And that's why I think, as you emphasize, educating the care partner is so important.
Beautiful.
That this is part of it can be very frustrating. These are the things to do. The other thing that's very important, and this is also for clinicians, is to be able to differentiate depression from apathy. They're not the same. Okay. So depression, we still use the criteria for clinically significant depression and looking for vegetative signs and symptoms and so on, because the apathetic patient generally does not respond to antidepressants.
I'm going to ask you to tease that out for us a little bit more. What specific vegetative signs are you looking for that would point you in the direction of depression versus apathy? How are you teasing those apart?
Yeah, so apathy basically frustrating for the care partner, but the individual doesn't really have other symptomatology, whether we're looking at changes in appetite, changes in sleep, um, maybe change in affect, change in mood. Maybe the depressed dementia patient might occasionally say something to their care partner, not that, not to say that I'm depressed, because they don't say that. They often don't have that insight, but they might occasionally say something like, well, maybe I just shouldn't be around anymore. I wish I was dead. And then it doesn't last. But those are little glimmers into how the individual feels. And I think the care partner also feels what the patient feels. So if we ask the care partner, do you think that a lot of what's been going on with your wife or your husband or with mom or dad or whomever, do you think they could be depressed? And often they'll say, yeah, I really think he's depressed. He's just very different than he was before. And I found that when we go with that type of insight from the care partner and aggressively treat the depression, we get very good results. And depression in all of the major neurocognitive disorders, some even more than others, is very, very common.
Gosh, it makes me want to do a whole hour on the dyadic relationship between a care partner and a patient who is experiencing this disorder. Such an intimate relationship, and I think they're really the emotional states of each one affects the other really deeply.
So we were talking about the more specific kind of syndromes, and we started with apathy because across the board, across all the major neurocognitive disorders, numerically, it's the most common. But it doesn't get a lot of attention because the quiet, the couch potato kind of patient doesn't, like I said, doesn't make waves. While it can be frustrating to the care partner, it's very different than the aggressive, out of control patient, or the vividly psychotic individual, or the horribly depressed person.
And for me, what it brings up is maybe in this family of disorders more than any other family of disorders, the importance of collateral. It's one thing to examine the patient, to take the history from the patient, but the care partner knows the patient so intimately that a lot of times the majority of the history is going to be provided by somebody else. And we need to really trust that, make sure to seek that really deliberately. And oftentimes the key to unlocking the case is actually going to come in collateral in cases like this.
Totally. And that was actually, I had alluded earlier when you and I talked to this decision tree for healthcare providers for agitation, which is one of the neuropsychiatric symptoms. First thing that we emphasized in trying to figure out what's going on is basically getting a good history from the care partner,
From the care partner.
listening to them, because the patients are not going to often be able to tell us what's going on, but the care partner can, and we have to speak to them at their level, use their own language, not use our own technical language. And pretty much at every visit for clinicians who are seeing dementia patients with their care partners, at every visit, we need to ask about these things. Has there been any behavior change? Has there been a change in personality? Are there some things that are happening that make it harder now for you to take care of your loved one with Alzheimer's disease? And then, if yes, the answer is yes to any of those, to get further details, and then we go from there.
I love it. So we started on one end of the spectrum with apathy, something that often goes unnoticed because it doesn't make waves. Let's talk about the other end of the spectrum. When we're talking about delusions, paranoia, how does this typically present in major neurocognitive disorder and maybe as opposed to in a primary psychotic disorder?
Yeah. So we had a really good case, a good example of this just a couple of weeks ago at one of our teaching nursing homes, where one of our patients, who's been diagnosed a number of years ago with Alzheimer's disease, now is moving toward the more advanced stages, started to suspect that the staff were stealing things from her. One evening, for example, she thought that she had put her watch in the top drawer of the nightstand next to her bed. And she wakes up in the morning and opens the drawer, and the watch is not there. So next thing you know, she starts accusing her roommate, accusing the staff, someone stole my watch. At which point, one of the nurse's aides comes into the room, is looking everywhere, and finds the watch underneath the nightstand on the floor. Okay. But nonetheless, she became, very, very upset and accusatory. It started that way. And next thing we know, she's accusing the staff of maybe trying to poison her, she refuses to take medication. She's even worried about the food that the dietary folks are preparing because she's becoming more and more suspicious and paranoid and convinced that they're trying to harm her and, in fact, even trying to poison her. So that's a very kind of obvious case of kind of paranoia, more of a delusion rather than hallucination. Even more common, especially in Alzheimer's disease, as far as psychotic symptoms, would be visual hallucinations. A recent patient was reported by the family to constantly be looking out the window. And at times, she would get really scared. And they would ask her, "Why are you so scared? What's going on out there? I don't see anything." And she would talk about frightening creatures that were outdoors that were trying to come in to the room, into the house. So it was actually having overt visual hallucination. I mentioned earlier that there can be visual hallucinations that often precede the earliest manifestations of Lewy body dementia. There, the visual hallucinations can be very different. Almost always, it's something like they're seeing, let's say, children or animals that other people don't see. Sometimes they're disturbing, sometimes they're not. So there's just a whole range of different, both delusions and hallucinations in the range of neurocognitive disorders that are part of the psychotic spectrum.
Any other specific NPS that you think deserve a picture painted, or should we go ahead and move on to the next portion?
Well, no. So I think the other point to make about psychotic symptoms, and particularly about delusions, which are very common in Alzheimer's disease, is that there are what I call kind of benign delusions, or benign first firm false beliefs that patients can have. And an example of which don't require, antipsychotic medicines or aggressive kind of intervention. An example of this would be a patient who, let's say it's a woman with Alzheimer's disease who's married in the middle stages of the disease, and she and her husband are sitting in their living room one afternoon. They're watching TV or whatever, just together. At which point she turns to her husband and she says, "Bob, take me home. Take me home." He says, "Take you home? Well, this is our home. We've been living here for 25 years." "Oh no, I don't live here. I live on 1800 Cabanny, which is where she grew up. Where is where she lived when she was a child and growing up with her own family." So that is a delusion. It's a firm false belief that's really hard to shake, technically a delusion. But do you want to treat that with an antipsychotic medication? No. The way he treated it was, "Hey, it's a nice day. Let's get in the car. I'm going to drive you back to the old neighborhood where you grew up. And we can talk about your house and about mom and dad and your siblings. And then we're going to go out to eat and do whatever." Next thing you know, that was no longer a problem. So there are these more benign delusions that I call that are based on cognitive loss because of a retention of remote memories and more difficulties with recent memory. She remembers her childhood home better than recognizing her current home as being hers.
That's a beautiful example, and my heart goes out to our listeners who are listening to you speak on their way to work, and they're going to have to walk into work with tears streaming down their face because of that story.
So I think we've been talking about, we started talking about apathy, and then we moved to psychosis. Okay. There are other, I think, very common neuropsychiatric symptoms in the dementias, particularly in Alzheimer's disease, that I think we should talk about. So we mentioned agitation earlier, the spectrum of agitated behaviors from mild anxiety, irritability, to overt agitation, to even more overt physically aggressive kind of behaviors. Those are very common. They affect maybe at least one in two, at least 50% of Alzheimer's patients. And then the numbers are probably the same, maybe even higher when we talk about mood disorders, depression in the context of any of the neurocognitive disorders, probably most common in Parkinson's dementia, but we do see it in Alzheimer's disease quite commonly. And I think, Mark, if you come to our clinic and just kind of review charts of our Alzheimer's patients at different stages at any one time, at least half are on antidepressants.
That checks out. And we're going to speak about antidepressants just kind of as a class here shortly. One of the things that comes up when you tell the story of the redirection is a major question in all these cases, because a lot of our interventions, especially for this population, do have significant risks as well as significant benefits. Is we're really making a judgment call as to what types of symptoms are not distressing enough that I'm able to simply redirect, to manage behaviorally, to use psychoeducation, and then at what point do the symptoms become severe enough that we need to intervene psychopharmacologically or otherwise. And I think that's a difficult judgment call for any clinician dealing with this population to make. But it's important to keep in mind that it's not just symptom treatment. It's symptom, duration, severity, etc., functional impairment being caused. And then you need to look at the specific intervention that you're proposing and say, is this worth the risks? And in the case of the benign delusion, what a beautiful way to deal with that patient who might otherwise be placed on a medication that will have some side effects that they would have to live with. So I think that was a really, really good example that you painted for us.
I agree.
We're approaching this season from the consult liaison lens, and this is another really broad question for you, but I'd like to just see kind of what your general approach would be. So it's a very common consult on the inpatient psychiatry consult service. Patient who has a history of a major neurocognitive disorder, who is now experiencing some sort of NPS. Usually it's agitation, occasionally it's hallucinations. When you are fielding that consult and going to approach the patient, what is your general approach? What are kind of the boxes in your head that you're making sure to tick? Who are the people that you're making sure to talk to? Are there any standardized tools that you're thinking about right off the bat that you want to get on this patient, et cetera?
Yeah, so I think maybe as you're pointing out, probably agitation or the spectrum of agitated behaviors is probably most common in that scenario on the consult service against a background of a major neurocognitive disorder. Could be Alzheimer's disease most often, but maybe some other things as well. I think, as with seeing outpatients or patients in long term care, I think an informant, a reliable informant, is always very, very important. Is this something different? Is this something unusual? Is this something that's just happening now? It's more kind of abrupt onset. Or are we looking at something, an exacerbation of something that's been going on for quite some time, even at home before the hospitalization? Now, because you're talking consult service, you're talking hospitalization, we also have to be mindful of comorbid medical problems and underlying issues not related to the dementia, not related to the major neurocognitive disorder, that they themselves might be the trigger for this behavior change, such as agitated behavior. And this is actually part of that decision tree for healthcare providers that we developed, where the message is when you have the kind of patient on the consult service that you're describing, or in the nursing home, for example, where we're doing consults there, which is like a hospital in many ways, and the patient has a dementia like Alzheimer's disease or other disorders related to that, don't automatically assume that this agitation or irritability or behavior change is coming from the major neurocognitive disorder, but look for other possible underlying factors. And the things that really, really stand out would be the many different causes of delirium, whether it's bad drugs, anticholinergics, benzos, narcotic analgesics, you name it, infections, urinary tract being most common. Could it be pain in a patient that can't tell you that they're in pain, much less where they're hurting? There are a lot. Could it be environmental changes? We need to think about all these different triggers before we say, and rule them out before we say, no, this is not it. This is coming as part and parcel of their Alzheimer's, dementia, or whatever the major neurocognitive disorder may be. And then we need to intervene. And I think, as you really, really well pointed out, then the question becomes, how acute is the problem? Is there an issue of safety for patient or others in the environment where you may have to go to pharmacotherapy because of the safety risks just to get the patient under control so we can buy ourselves time to figure out what's going on? Or are we looking at something that's, relatively tolerable? There isn't much disability. It's not a disabling symptom, in which case we do have the luxury of time to figure it out. Once we've figured out that it's not coming from these other triggers, but maybe is part and parcel of the dementia, like Alzheimer's disease, then we have a range of different therapeutic options. Every treatment guideline, this is the International Psychogeriatric, the American, the APA, the most recent Canadian guidelines, the guidelines we put together for the Geriatric Society, every single one of them calls for starting with non-pharmacologic interventions first, unless it's an urgent situation where it's a safety issue. The emergency room with the out of control violent patient or someone even on consults, then you may have to go to pharmacotherapy first. But generally, we always want to start with non pharmacologic approaches. And there are many of them that can be very useful. If those don't work, or you don't have the luxury of time for those to kind of kick in, then pharmacotherapy would be indicated. And there's a range of different pharmacotherapies that are either available, on label, off label, or are being investigated.
You use the word time in that response a bunch of times, and I want to really hammer home this point because spending time with our patient, spending time with the person providing collateral to build an alliance, to get voracious information that's going to guide our treatment plan is absolutely crucial, and there is no substitute for it. And if we simply read a chart and look at prior diagnoses and see a patient in 10 minutes, we're going to be treating someone for agitation with Risperdal when it turns out the person doesn't have their glasses or hearing aids. And that's why they're agitated, because they don't know what's going on because their sensory modalities aren't working. And so I really, really appreciate your point that it starts with the history. It starts with a really firm history, and there's no excuse for not taking the time with our patients.
It's harder on the consult service because you're
Yeah.
seeing patients that you don't have a relationship with. But even in outpatient clinic, I'm a big advocate of what you're saying and spending a lot of time. Believe it or not, we spend 2 hours with new patients and families for our initial evaluation. These are very complicated, older adults with not just cognitive issues, but a variety of comorbid medical problems. They often come with a bed list that's 12 or 13 or more prescription medications, which may be part of the problem. But we also spend a lot of time because that's our opportunity to develop that therapeutic alliance with the family. That's our opportunity to get them to realize that we are working together. We are one team. You are working with us. We are working with you. We have the same goal. And the only goal that we have is to be able to help your loved one to function as well as possible for as long as possible. And to help you as the care partner, hopefully make it a little bit easier for you to be able to continue to be a care partner for your husband, for your wife, or mom or dad, or whoever the patient may be.
Beautiful. So, having given our due diligence to the history taking, the physical exam, the assessment, let's not talk about treatment strategies a little bit. You mentioned that all of these guidelines start with non pharmacologic approaches. Could you be more specific when you say that? We talked about psychoeducation. I think that's crucial. What other non pharmacological management approaches have been found to be helpful for NPS?
So we've actually written about those, but it's I think it's a very important area, and it's an area where we probably need more. I think controlled studies, larger numbers of patients. It's hard to do sometimes controlled trials with non-pharmacologic approaches, but there are many. I think to begin with, before we talk about any non-pharmacological intervention, it's a good idea to know the patient and know their interests, know their hobbies, know things they like, know things they don't like, stay away from things they don't like, and to adjust the non pharmacologic approach to the specific patient centered kind of approach. And I'll give you a really good example of this. One of the areas where I think we have pretty good data that showing that it can be helpful for irritability is music therapy. There are a number of studies that have looked at the benefits of music therapy. Um, when we had our inpatient unit, our geriatric psychiatry unit at SLU, we admitted a gentleman with Alzheimer's disease for severe agitated behavior that was kind of getting hard to control. The family was really worn out. And what we did was we took him one afternoon on the unit to music therapy. So we would have every afternoon regular music sessions. And that afternoon, the music session was basically the music of Frank Sinatra. So everybody got together, and our activities therapist was, basically having Frank Sinatra kind of singing his famous songs. The patients with major neurocognitive disorders, all of them some of them sung along. It's amazing how you can remember songs, and they were really enjoying the session. Whereas my patient was getting more and more agitated, and we had to take him out of the music session. We later found out from his wife that although he liked music, his whole life he hated Frank Sinatra. Now, we didn't know that. And we know that we would not have taken him into that session. But so you have to individualize the approach. One thing that I really, really preach in the outpatient clinic and in the nursing home and all the settings where we see Alzheimer's or dementia patients is the importance of keeping patients active and maybe even having an hour by hour, day by day activity schedule, because the bored patient is the irritable patient. You don't just want patients sitting around, staring at the nurses at the nurses station. You don't want too much downtime, but you really want to have a schedule of activities. But there can be exercise, music therapy, pet therapy, robotic pets, even. We wrote an article recently, which has been highly referenced, on doll therapy, an androgynous doll, which can be useful for some agitated behaviors. There are aromatherapy, massage, hands-on things. But I think the key is really to keep the individual active, to give them diversionary activities. And then, of course, to look at the environment. If there are environmental triggers, loud music, not music, but noises, or bright lights that are too bright, or a disturbing roommate, let's say in the nursing home. We had a patient recently of mine who's doing very well in the special care unit of one of our teaching nursing homes with Alzheimer's disease. He's in a semi-private room. He was by himself because he didn't have a roommate for a while. And then all of a sudden they move in a gentleman as his roommate who's very verbally agitated, who's very noisy. I get a call because now my patient is even more noisy than the roommate is, and they want to know what to do. I said, well, have we thought about maybe switching roommates or switching rooms? And that worked. A quieter roommate, a quieter environment. So there are many different non-pharmacologic approaches which need to be fine-tuned. We need to know the patient. That can be very helpful in ameliorating particularly agitation. Now, again, these approaches are not going to help someone that's vividly psychotic or someone that's severely depressed. That's a different issue. And they probably won't help apathy all that much either, although maybe an activity schedule, if you don't ask, but you make them do these things, might be a bit helpful.
We might have to clip that audio and send it to the Office of Mission and Identity here at SLU. One thing that our listeners don't know about me yet is I am now in my 13th year in a row at a Jesuit institution. It's something that's really special to me, really important to me. And what I'm hearing from you is the importance of taking care of the whole person, mind, body, spirit, and knowing who this person is, not simply knowing the information about the patient, what the disease is, what the treatments we've tried are, which is super important as physicians and scientists, but who is this person? What moves their soul? What gets them going? And it's really a much different level, I think, of medicine than is commonly being practiced. So I really, really appreciate you calling that out. Let's move now into the pharmacological. We're going to go class by class here, and you're going to kind of tell me what you think the role of each one of these classes is in management of NPS. You mentioned that maybe over half of your patients in your clinic for patients with major neurocognitive disorders are on antidepressants. So I guess I'd like to start there. What types of things are antidepressants helpful for? Do you have any specific antidepressants that you tend to lean toward? What's the role of antidepressants in treating NPS?
Yeah, so I think NPS again is a very broad category. So we do use antidepressants in a variety of ways, but of course, most commonly we would use antidepressants to treat depression against a background of something like Alzheimer's disease or Parkinson's dementia or other kind of neurocognitive disorders. We tend to really focus, as far as antidepressants are concerned, on safety and tolerability. This is an older, sensitive, vulnerable population, and some of the medications have been better studied in older adults than others. Some have maybe higher levels of particularly cardiovascular safety, as a lot of our patients have cardiac and cardiovascular issues. So we may prioritize those, especially for depression treatment. So I'm thinking of sertraline, for example, with all the data, the SAD heart study, and so on, might be a really good choice for someone where they have AFib or they have arrhythmias of other sorts, a lot of cardiovascular issues, and safety would be predominant. On the other hand, we also use a variety of antidepressants, depending on what kind of side effects we want or what side effects we don't want in a particular patient. So we may use antidepressants that are more activating in someone that's more apathetically depressed, or someone that has more of an irritable or agitated depression. We might want something more calming. In that regard, the best data for antidepressants as far as calming effect is with citalopram. And there have been some well-known studies with that drug showing that at higher doses, higher than we actually recommend in older adults, 30 milligrams a day generally. We recommend usually no more than 20 because of cardiac issues. It can have a very nice calming effect. So we select antidepressants in this age group and in this population similarly to how we select them in younger adults, by what side effects we want and what side effects we don't want in a particular patient. We do use the SNRIs as well, particularly duloxetine, because a lot of our patients also have neuropathy or have other painful conditions, things where we can kind of kill two birds with one stone. And that's a drug that has, many different indications, including anxiety, depression, neuropathic pain, fibromyalgia, all kinds of things. So that's something that we use commonly. We also not uncommonly use psychostimulants. We may use them for augmentation purposes. Do use them in apathy, as we mentioned as well. So we use a broad range of treatments. And then, of course, ECT, electroconvulsive therapy. There's not been a lot of experience with TMS in depression in Alzheimer's or dementia patients, but that can be another option. Um, have not had as much success with dementia patients with ketamine or esketamine. Sometimes the out of body experiences are very frightening for them, and they often don't go back or don't go back for further treatments. But there's just a whole range of good options. Interestingly, there is some growing evidence that individuals with Alzheimer's disease who are on antidepressants, specifically SSRIs, for either treatment of anxiety and or depression, over the course of the disease, do better. That may actually have a beneficial effect on rate of progression. That doesn't mean we should put everybody on them, but when they do get on these medications, they tend to do better.
Interesting. So I want to underline this piece about the antidepressants here briefly. I think it's intuitive that antidepressants would be used for something like low mood, intuitive that they might be used for something like anxiety. But I think one of your points here is oftentimes in these patients with low cognitive reserve, with limited ability to cope and express themselves, things like sadness, anxiety, etc., might manifest themselves as agitation. And so you are actually using antidepressants as an intervention for agitation in some patients. Is that a correct summary?
At times, yes. So if we have what we kind of would call an agitated depression, then a kind of a calming antidepressant would be a good treatment choice.
You mentioned ECT there as well, so I'd like to spend a little bit of time talking about that. First of all, any guidance for our listeners on the safety of ECT in this older population?
Yeah. So ECT, let's assume, for example, that patient doesn't have dementia, but is 90 years old. Okay, maybe a reasonably healthy 90-year-old, but now has become severely depressed, and maybe is not responding to pharmacotherapeutic interventions. ECT is absolutely the treatment choice. And one of the things that we talk about is that advanced age may be an indication for depression rather than a contraindication, because often they don't tolerate the medications very well. And it works quickly and has a very, very high success rate. Now, if we move on to the individual who has cognitive impairment, also with either treatment resistant or severe depression, they do just as well, but we need to be mindful that we may need to be using different techniques to minimize cognitive loss or memory disturbances, which can be part and parcel of ECT. So we have what we call kind of a memory sparing technique, which is basically ultra high frequency, unilateral, non dominant hemisphere ECT, which can really minimize the cognitive changes and still help with the severe mood disturbance. So that's always like our bottom line. The other area where ECT can be helpful is in treatment resistant agitation, where the individual either is not able to tolerate or doesn't respond to any of the pharmacotherapeutic approaches. They're very aggressive, maybe even violent. ECT can have a really good dampening effect on that type of behavior. So, again, it's kind of not the first line, but it's kind of a bottom line treatment that's always available for us that can be safe, well tolerated, and quite effective.
The final case that I would add to that we see on the consult service not infrequently is a patient who is losing weight rapidly. They've had a medical workup. We can't find a medical reason for what's going on. And it seems like the weight loss might be secondary to either a depression or the apathy, a neuropsychiatric symptom of dementia. Do you think that ECT can be helpful in those cases as well?
Absolutely. Now, I would, in that case, I would probably first try a psychostimulant. It's kind of interesting. Some we
It is.
usually use
I would not have
on
guessed that. Go ahead. Sorry.
you know, it could be, it's interesting because it's somewhat counterintuitive. And I try to explain this to families as to why we're recommending, a medication that's used in kids who are kind of hyperactive. And what I tell them is that, yes, it's true that, in children and sometimes in adults as well who have ADD or ADHD, a psychostimulant, a medicine like methylphenidate, Ritalin, whatever, uh, can often help them with concentration, with focus, can kind of slow them down. But in adults, younger, older, middle age, whatever, but in our older adults that we're talking about today, when we give them low doses of a psychostimulant, it stimulates appetite. It gives them more energy. It decreases some of the apathy and can be a good way to start to get them to eat right away or at least take some nourishment while we wait for the more traditional antidepressant, whatever our choice antidepressant was, to kick in. So that's another option, especially on the consult service, to consider. And at low doses, thinking about 5 milligrams twice a day of methylphenidate, morning and after lunch, maybe up to 10 milligrams twice a day, you should not have any impact on cardiovascular parameters like blood pressure, heart rate, and so on.
That's one. It's wonderful to have you on with all of your wisdom. That's not something that is very intuitive to me, but it perfectly makes sense. And um, thank you for sharing that with us. Let's move on to antipsychotics. I think this is a hot topic, especially considering some of the box warnings out there, some of the mixed evidence out there. Um, where are you most commonly using antipsychotics in the management of NPS? What are they helpful for? And what are the really significant risks that you're having to balance when you're thinking about using antipsychotics in this population?
Yeah, so obviously you mentioned the box warning. The one that we're most concerned about, obviously, is increased mortality in dementia patients with psychosis. And we don't have right now any FDA approved medications for psychosis in Alzheimer's disease or in dementia. There are a number of things in the pipeline, and I'm working with a couple of different companies that have kind of unique we'll put it in quotes, antipsychotics. They're not traditional antipsychotics like we're used to, that are being targeted specifically for psychosis in Alzheimer's disease and could have broader applicability in other dementias. So for now, we're using what we have for psychosis. And again, we pick the drug based on what side effects we want or don't want in this vulnerable older adult Alzheimer's patient or dementia patients. The good news is that the other area where we've been using antipsychotics, maybe way too liberally, without having good data to back it up, is that we now have for the first time an FDA approved medication for agitation in Alzheimer's disease, and that's brexpiprazole. And just because of full disclosure, I have been a consultant to the company that and helped them to develop that drug and get it approved by the Food and Drug this past year. So that is I think, a very legitimate approach. The limitations of brexpiprazole, which is one of the reasons why often other antipsychotics are used off-label, is that you have to gradually build it up, and it takes between 2 and 4 weeks to begin to optimally kick in. And then as you continue treatment beyond the 4 weeks, you see more and more efficacy. But if we have an emergency on our hands, I think you probably know, Mark, that in many emergency rooms, including ours, what the emergency room doctors do is they use olanzapine. And the out of control, aggressive, violent patient, no matter what their age, they might use a bigger dose in younger people and a little smaller dose in an older adult, but they need to get the patient under control. They're going to use a major tranquilizer, basically like olanzapine. They can give it IM, they can give it PO. There's the wafer dissolvable form and so on. And then at least they'll get the patient under control to buy them time to be able to work them up and see what the trigger is. Do they have a UTI? Did they have something else going on that could be a trigger or contributing to their aggressive or violent behavior? In some countries, not in the US, in Canada and some European countries, risperidone is approved for acute aggressive behavior in dementia for short-term use. But the reality is that all of the drugs that we normally use off-label have for agitation and even psychosis have major side effects and liabilities in this patient population. So it's always kind of weighing the risk benefit ratio, and not just a box warning, but other side effects, whether they're extrapyramidal side effects, sedation, orthostasis, increased risk of falls, more confusion, depending on the agent that we use. So we have to use them very, very cautiously. And we do need, I think, more FDA approved medications that are safe and better tolerated and effective for all of the neuropsychiatric symptoms. Because right now we have only one and one indication.
So you mentioned risperidone, you mentioned brexpiprazole, which does have that FDA indication, and thank you for your full disclosure there. You mentioned olanzapine. One of the things that you're getting across to us is that each individual patient with their individual constellation of symptoms and comorbidities, we can't just say this is the med for this indication. We have to think really discreetly about what exactly are we trying to achieve with this patient. A couple of 2006 meta-analyses that I found in my pre-work, aripiprazole, as well as risperidone and olanzapine, was superior to placebo in management of agitation in BPSD. Quetiapine also had some evidence in a 2019 meta-analysis with improvements in BPSD. So you have a lot of kind of options here. I think pulling the lens back a little bit, though, what we're really thinking about is what does the quality of life for this person look like, and what can I do to enhance the quality of life with the time that this person has left, right? So when we're thinking about the significant risks to these medications, we have to also think about the significant risks to the patient and family if we don't treat violent behavior, right? If we don't treat extremely distressing psychotic symptoms. And so we're really balancing what can I do to help this person to live a meaningful life with their time left. And I think in this population, at times, that means accepting significant risks while, of course, discussing those and disclosing those with the family.
Yeah, I agree with that. I think the other point to emphasize, because you brought up the meta-analyses, uh, the studies that have been included in meta-analyses have often been relatively small, uh, maybe controlled, usually controlled, but short-term studies, often at doses which over time might kind of catch up with the individual. There's a cumulative effect. So for example, you mentioned quetiapine. As far as I know, there's only been one relatively sizable randomized placebo-controlled study with quetiapine, which was done many years ago. And I believe the effective dose that they used in that study was 200 milligrams of quetiapine a day. Now, that may not sound like a lot in a younger patient, but in an older patient with a variety of comorbid issues, including the underlying neurocognitive disorder, 200 milligrams will be enough not just to maybe calm them down, but also to sedate them, increasing the risk of falls. And depending on the individual, might be also enough over time to cause or exacerbate orthostasis, increasing again the risk of falls. So the data with the conventional as well as the atypical antipsychotics for this patient population is relatively sparse, um, especially for psychosis, because most of these studies have looked at using the antipsychotics off label for agitation or aggressive behaviors.
I think this conversation is probably the meat and potatoes of what a lot of people tuned in for. And I think in my training and certainly across the globe, antipsychotics are commonly being used for this indication. So I know you know the literature really, really, really well. Thank you for sharing those specifics with me. I want to give you an open mic on antipsychotics and BPSD. Is there anything else that you think is really important for people who do not have geriatric psychiatry fellowship training and are having to make these clinical decisions, sometimes in countries that don't have very limited options, that are kind of freely listening to your expertise? Any other tidbits that you want to share with our audience on this?
We talked about emergency room and emergency situations, at home and or in the nursing home, for example, or in the hospital setting, where you have a violent or aggressive patient, and your number one priority is to get them under control as quickly as you can to give yourself time to kind of evaluate what's going on. So in those instances, I think what we use is probably not as important. Yes, I would use olanzapine. I might use other kind of sedating or calming antidepressants. And I don't want to use them long term. I'm using them acutely. But in the case of individuals that have persistent agitated behavior, where you've ruled out underlying triggers, or individuals with psychosis, it's not going to kind of go away. You really want to pick an agent, whether on label or off label. You want to pick an agent that's going to have the best possible benefit risk or risk benefit ratio. And of course, because of all the warnings with the antipsychotics, it's very important to have a discussion with the family, with the care partners. And so they understand the risk benefit ratio. But when I have that discussion with them, given how miserable their loved one is, either with, very, very disturbing psychotic thoughts or, serious agitated kind of behaviors, how distressed they are, the patients are, and the families are. I've yet to have a family tell me, "Oh no, please, doctor, don't use these medicines with my wife or my husband or with mom or dad." They're very eager to do what we need to do to try to get things under as good control as possible. And very important that once we've achieved that, we don't want to continue these drugs indefinitely. I think we need to reevaluate ongoing need. In the nursing home, for example, there are rules, federal requirements that at least at 6 months, there needs to be a reassessment of all antipsychotics in this patient population as to ongoing need and as to whether, even if we think there might be an ongoing need, can we cut the dose? Can we do just as well with lower doses? There isn't a federal requirement to do that in the outpatient clinic, but we need to be mindful of that we need to periodically reassess because these drugs can also have what's called cumulative toxicity.
Beautiful. Thank you. Just a few more classes of medications, and then I'll ask you for your final thoughts for us. What about anticonvulsants? I think this has been one that's been controversial in the last 20 years, thinking about valproic acid Depakote, thinking about carbamazepine. Where do you think these fit into our kind of algorithm for managing NPS?
Well, they're bad, but no. So I'll tell you an interesting story. A number of years ago, and this goes back quite a number of years, when the box warning first came out for treating older patients with dementia, with kind of psychosis and increased risk of mortality and so on. And people were also worried about using the antipsychotics off label for agitation. A lot of clinicians turned to the anticonvulsants, particularly drugs like divalproex or valproic acid. We use the buffered version, divalproex, also to oxcarbazepine, carbamazepine, and the data is really, really poor. Um, pretty First of all the studies are small. Many of them are open label with all of the anticonvulsants, and these are difficult to tolerate drugs in older patients in general. So we try to really avoid them. Carbamazepine, you mentioned, has a lot of drug-drug interactions, a lot of side effects. Depakote or divalproex, valproic acid, whatever, sedation, all kinds of terrible side effects, and the data as far as efficacy is not good. And then you look at I guess, my neurology colleagues' most favorite anticonvulsant, which is levetiracetam, also known as Keppra. They use that like water. One of the major side effects of that, also in older adults, is akathisia, restlessness. So using that in an agitated patient, not a good idea. So we try not to use the antipsychotics or the anticonvulsants, I'm sorry, because they don't have good data. And the studies that are out there are small, mostly uncontrolled. So I would stay away from them.
Yep, I hear you loud and clear on that one. Thanks for your clarity for us. What about cholinesterase inhibitors? Where do these fit into the NPS management?
I'm a big believer. Full disclosure, I helped develop the rivastigmine transdermal Exelon patch, which is one of the cholinesterase inhibitors, and happens to be my favorite cholinesterase inhibitor for various reasons. But that's neither here nor there. So I'm a big fan of combination therapy in Alzheimer's disease, and I have been for a long time. And I think more and more people, agree with that. The notion of starting with the cholinesterase inhibitor and then adding the NMDA receptor antagonist, and we just have one, which is memantine. That's combination therapy. And then maintaining that combination over time. I think there's growing evidence that combination therapy over time may decrease behavioral or neuropsychiatric symptoms, a whole range of them, in the middle and later stages of the disease. It's not, 100%. There are some patients that obviously will still get them. So that's not a bad idea. But neither the cholinesterase inhibitors nor the NMDA receptor antagonist are drugs that are going to work in the near future. These are drugs you have to build up, titrate, and maintain for months and years before we're going to see maybe some behavioral impact or minimizing the emergence of problem behaviors. So they're not very useful for most of the situations that we're talking about.
And the last class of medications where I think there's some evidence, some controlled trials, benzodiazepines for this population, right? Benzodiazepines are first line for agitation in undifferentiated agitation, especially in younger individuals. So it's not unreasonable to be thinking about benzodiazepines when we're thinking about agitation. How do they fit into managing agitation in NPS?
So I think you know very well when we talk about the Beers list of kind of bad drugs in older people, and the benzodiazepines are very much at the top of the Beers list. So in general, we don't like benzodiazepines in older adults, especially those with cognitive impairment, particularly longer term use. That doesn't mean we never use them. We sometimes use them for in low doses for treatment resistant kind of anxiety or irritability. But in this patient population, other than maybe acute use, where you maybe need to get dangerous behavior under control, very short term use, we don't like the benzodiazepines. Several reasons. One is they're sedating, which increases the risk of falls. Secondly, they impair balance in this patient population, which even more so increases the risk of falls. And then thirdly, they further impair cognition. And do I want that in my patient who's already cognitively impaired? So we really, really strongly recommend staying away from benzodiazepines unless you have to use them in an acute emergency situation. And my preference in the acute emergency situation wouldn't be a benzo. I would go with a sedating kind of antipsychotic acutely, because even that would be better tolerated than the benzodiazepines would be. So that and the anticonvulsants are probably the two groups that we stay away from. And the data that you alluded to, again, no large controlled studies. A lot of studies are small, sometimes open label, anecdotal. And then I think the liabilities far outweigh the potential benefits.
Very concise for us. And again, I know that this topic is really broad and really heterogeneous. So, kind of covering it as one entity in 1 hour and going through each class of medications is a very difficult task to perform because, as you're showing us, there's such nuance depending on each individual patient, what their presentation is, what other medications they're on, et cetera. But my sincere gratitude for trying to bring this down to a sort of boot camp level that will help our listeners all across the world.
My pleasure.
Any final thoughts from you for our audience?
I think one of the things that would be helpful would be to kind of focus on the individual neurocognitive disorders and what are the common neuropsychiatric symptoms in each of them, and what are the diagnostic and treatment approaches. Because, like you said, this is a really broad kind of area, and there's just so much research and new things that are happening in each of these areas. It could be a lot of fun. But a bottom line, I think, for all of us as kind of clinicians who are working with older adults and their families with, major neurocognitive disorders, particularly Alzheimer's disease, but all of them is the importance really at every visit. And we mentioned this earlier, the importance at every visit of touching base with that reliable informant, usually the care partner, and asking them about changes in behavior, changes in mood, changes in personality, changes in your ability to care for this individual, to be able to hone in on the notion that one or more of the neuropsychiatric symptoms is present and it's problematic and we need to do something about it. Because a lot of times the care partners don't tell us unless we ask. They might be embarrassed. There might be a stigma. As you pointed out earlier, Mark, they may not realize that this is so common. Yes, 50% of people with Alzheimer's disease do become agitated. There's nothing to be embarrassed about. This is something we need to work up and evaluate and try to develop a treatment approach for. So if we don't ask, they may not tell. So it's very, very important for us to include that in our initial and then subsequent visits with patients.
Consistent with your reputation, bringing us back to the humanist before we close, to remind us that while we can know the evidence like the back of our hand, what's most important is knowing the patient, taking the time with the patient, and destigmatizing these problems for the patient, for the caregiver. One of the things that always strikes me when I'm studying for board exams, answering multiple choice questions, et cetera, is the amount of data that is given in the STEM. I'm like, how are we ever going to know this, right? It'll give me everything the patient's ever taken and all of the diagnoses they've had, and I just think, like, in my 30-minute clinic visit, how am I going to get this from the patient or the caregiver to make this decision? And it really is just through building that strong therapeutic alliance, taking the time to listen, taking the time to educate. I think when we educate, we destigmatize for people. And when we say, this often happens, does this happen to you? Sometimes that lifts a load off their shoulders and really helps them to help out their patients. So thank you, Dr. Grossberg, for everything you've done for me so far at SLU, and especially for coming on this podcast and sharing your hard-won expertise for our listeners.
Thank you. I enjoyed it. Look forward to working with you in the future.
We will plenty. Thank you. Take care. Thanks for listening to this episode of Psychiatry Bootcamp. If you enjoyed the podcast, please take a minute to leave a review on Apple Podcasts or a rating on Apple or Spotify. You can reach me at psychiatrybootcamppodcast@gmail.com. Find me on TikTok or Instagram at Psych Bootcamp. Our theme music is by Cave Radio. Special thanks to Matthew Braddock for production support. The opinions shared on this podcast do not reflect the opinion of any institution, including host or guest employers or podcast partners. This podcast is not intended to be used as medical advice or in any legal proceedings whatsoever, including to establish a standard of care. This podcast is intended only as a supplement to a complete, accredited psychiatry residency and is grossly inadequate to rely on for medical decision-making. It is intended to entertain and inform. You should always rely on your own clinical judgment when making medical decisions and contact your physician for medical advice. This is a Human Content production. Hey everyone, thanks for watching. If you enjoyed the show, please remember to subscribe to the channel. If you'd like more episodes, you can click right here. I'd love to connect with you more, and I'm looking forward to talking to you next.